the manufacturer of HeRO. Today, we're going to talk, kind of set the stage with what's changed in neonatology since 2010 or so. Talk about HeRO, how it was developed and its predictive ability, other metrics of model performance. Get into the HeRO randomized control trial, the largest ever randomized control trial among preterm infants. Go through clinical workflows, and then some of our current efforts, including SpO2 targeting, HeRO Plus, neonatal opioid withdrawal syndrome, our efforts on adding new physiological variables such as accelerometry data from the limbs of NICU patients, our growth and nutrition efforts, talk a little bit about predictive models and some concluding thoughts, and then have some time hopefully left over for questions and discussions. We will be scanning the Q&A. So if you would like to post a question, we will be scanning that, and I'll get notice of that and hopefully can respond to your question in real time or save it for the end of the meeting. Okay, so moving forward, so setting the stage, what's changed in neonatal outcomes since 2010? So NICUs have indeed lowered antibiotic exposure and have raised their SpO2 target ranges, with 81% of European NICUs having SpO2 targets 3 to 5% higher. Lower alarm limits from 85, transitioning alarm limits from 85 to 89. But when they did so, odds of bronchopulmonary dysplasia increased. This increase in target ranges was also associated with an increase in ROP rates. So, you know, these changes have occurred. Everyone, I think, would agree that neonatal practice has changed. Yet VLBW outcomes are not improving. And Dr. Kemp in the Incubator podcast said it well. There is no large network showing improvement. And I'll just end it there. You can read the rest yourself. Indeed, if you go on the VAN website and look at their outcomes, they recently changed from reporting 401 to 1,500 gram patients to VLBW patients, but where there's consistency in exactly which patients they are reporting, which runs from 2011 to 2023. Late infection is down, and yet chronic lung disease, BPD, is actually up over that same time period. Mortality, death or morbidity, NEC, and ROP are all flat and unchanged, and we're seeing that over here. And indeed, Dr. Kemp published this, that among 16 VAN NICUs, 6 morbidity rates were unchanged and chronic lung disease increased. On the other hand, knowledge about HeRO has really grown exponentially over that same period, and we are now present in 25 countries around the world. So we really have learned quite a bit about what has changed with HeRO or what HeRO does and can do for these patients in that same time period, and that's a lot of what we are going to discuss today. So let's start at the beginning with HeRO development and predictive ability. So what is HeRO? So HeRO is an additional vital sign for NICU patients. It identifies abnormal heart rate patterns that are caused by cytokines. These, of course, are the markers of the inflammatory response, signaling mechanisms to tell the body to get sick. And so think of HeRO as a non-invasive, real-time indicator of inflammation in the inflammatory process. That can mean infection, be it sepsis, urinary tract infection, NEC, meningitis. It could be respiratory decompensation, both need for intubation as well as readiness for extubation. It can be brain bleeds, and that could be death. But in all cases, it can serve as an early warning system that leads to earlier diagnoses. And of course, earlier diagnoses lead to earlier treatment. Earlier treatment is more effective treatment. This can also mean better antibiotic stewardship, particularly in terms of targeting, and improved outcomes. We've seen all-cause mortality in the randomized control trial was improved, mortality after infection, mortality when measured at 18 months, mortality or neurodevelopmental impairment after sepsis when measured at 18 months, length of stay among survivors, and hospital revenue and profit. There are many different implementations of HeRO. We can sell it as a standalone monitor. It plugs into the back of your physiological monitor and monitors 1 or 2 beds. We can sell it as a network-based system. We call that HeRO Symphony, and it could even be integrated into certain brands of physiological monitor and show up right in the window or right in the glass with the other vital signs, sharing that same screen. But in all cases, we always show the most recent hourly HeRO score as a numeric and a bar graph, as well as a 5-day trend of those 120 hourly HeRO scores that may have occurred for a particular patient over that 5-day period. So again, cytokines mediate the inflammatory response. They have effects throughout the body, including causing these abnormal heart rate patterns. So if we were to walk up to the physiological monitor on a healthy patient and just watch the heart rate, we would see it bouncing up and down, 150, 152, 154, 148, up and down. That's good. That's both branches of the autonomic nervous system exerting control over the heart rate, and indeed the SA node, the pacemaker of the heart, responding to those inputs with this very chaotic signal. This is 30 minutes of heart rate data, and we can see lots of accelerations, lots of decelerations, a lot of chaos indeed in that heart rate pattern. Well, in the presence of cytokines, the way that the SA node, the pacemaker of the heart, responds to those inputs that it's receiving from the autonomic nervous system changes. And so now over here on the right, we fast forwarded, same patient, still 30 minutes of heart rate data, but now the patient is in the condition of about to be diagnosed with sepsis. So we are in this 24-hour window before sepsis is diagnosed, and yet we can see the heart rate patterns look fundamentally different. Now it's hard to see, but if you were to walk up to the physiological monitor for about a minute at a time, the heart rate would be consistent, beating like a metronome, 150, 150, 150, 150, over and over and over again. When it does finally change, it's a bradycardia, it's a subtle bradycardia, probably not even setting off the alarms, which are typically set at 100 beats per minute for at least 10 seconds. But you can see there's this drop in heart rate, it's a deceleration and no corresponding accelerations. And you can see that these two time periods for the same patient, when we look at the heart rate as a histogram, we can see that these two histograms are shaped very differently. And so we developed algorithms, both standard and novel measures that capture or quantify the degree to which this sort of abnormal heart rate pattern is present in a patient's heart rate signal. We then went through hundreds of patients of heart rate data and labeled it all as either well, coming well before or well after a sepsis event. We labeled the 24-hour window leading up to the sepsis event as heart rate data that was sick. And then we ignored a 7 to 10-day period for a blackout, where the patient is really, from a model training standpoint, neither sick nor healthy as they transition back to health. We used that as input into a logistic regression model and trained that model to identify these abnormal patterns. And indeed, the output of the model is the HeRO score, or the relative risk of infection in the next 24 hours based on heart rate patterns for that particular patient. And what we found down here at the bottom, if we lined up all HeRO scores from lowest to highest, and plotted that as this smooth line, that's what the predicted risk of infection looks like, or again, the HeRO score. And then these dots bounded by the boxes are the actual risk, the calibration of the model. And we can see then that the actual outcomes actually match, the observed risk actually matches the predicted risk very nicely. The other thing that you can see from this plot is that about 70% of HeRO scores will fall below 1. We consider that to be good or normal. 20% of HeRO scores will fall between 1 and 2. We consider that to be an intermediate HeRO score. And only the worst 10% of HeRO scores will fall above 2. We consider that to be elevated. But when you're thinking about these numbers, you're thinking about the HeRO score, just think of it this way. If you walk up to the HeRO monitor on a patient and they have a HeRO score of 4.1, that tells you that that patient is about 4 times more likely than they should be to have an infection in the next 24 hours. It's just that simple. So to summarize, cytokines alter heart rate patterns often before other clinical signs are apparent. The heart rate characteristics, or HRC or HRCI or HeRO score, they all mean the same things. They are specific measures of abnormal heart rate variability that the HRC index represents and quantifies as the amount of additional risk that that patient is facing compared to normal. Okay, so here's what it looks like when we pull up one particular patient and show that particular patient's HeRO score. And this is a patient that we're seeing the 5-day trend for that patient. And we happen to know that that patient was diagnosed at this yellow cursor where the score had spiked from 1 progressively higher over a 4-day period. And at the time of the score, the HeRO score was 4.9. At that time, the patient had clinical signs of sepsis and a positive blood culture. And as Fairchild and Ashner put it, these acute increases in HeRO score in the days prior to clinical deterioration may represent opportunities for earlier diagnosis and treatment, leading to better outcomes. Now, I would call this an absolute home run for the HeRO score. This was actually a patient that was a control patient, which we'll get to in the randomized control trial, where we were generating HeRO scores, but the clinicians were unaware of these HeRO scores for this particular patient. And so obviously we're not reacting to the HeRO scores. And we see this pattern time and time again among control patients where the score was rising and falling and rising and falling, in this case for about 4 days prior to the diagnosis. And one thing I want to call out here is when we are trying to capture the metrics of model performance, how well does the HeRO score predict sepsis? It turns out to be very difficult. Terms that we often use, sensitivity and specificity, are designed really to measure the impact of a single test, a single point in time test versus a single event. And they kind of break down when we are looking at potentially 120 points in the 5 days prior to infection. What we have to do is set a threshold of HeRO score above which are positives, below which are negatives. We also have to set a threshold in time before which a positive would be a false positive, after which a positive would be a true positive, and the inverse for negatives. And so you're seeing that here with these red lines. We typically set a HeRO threshold of 2.0, and we typically set a time threshold of 24 hours. So a HeRO score above 2 is a positive, and it would be a true positive only if it occurs within that 24-hour window leading up to the diagnosis. And so what you can see here is that all these early warnings, the rising and falling HeRO score in the days before the clinical event, are actually coming out as false positives. And indeed, this rising HeRO score, this final rising HeRO score in the 16-hour window or so prior to the diagnosis, includes these false negatives as well. And so with this one particular patient, with these data points, the sensitivity and specificity are 57% and 58% respectively. So again, here is a patient and a vignette that is clearly a clinical home run for HeRO, and yet our measures of sensitivity and specificity are actually quite poor. Point being is these metrics don't do an adequate job of representing the clinical impact that a continuous or near continuous score like HeRO can have on patients. And to further represent that, I'm going to go through some more metrics or ways of providing metrics of HeRO score, and you'll see that they really are all over the map. In one report, 92% of late onset sepsis was preceded within 24 hours by a HeRO score greater than 1, and 79% by a HeRO score greater than 2. So those are two different ways that you could assess sensitivity. Patients with elevated HeRO scores are at elevated risk of urinary tract infection, sepsis, or death over the next 7 days. So if we look at a patient's single HeRO score, one hourly HeRO score, categorize it as high, intermediate, or low, as we discussed on a previous slide, and then follow that patient for the next 7 days. This gives you a positive predictive value of around 15% for the high HeRO scores, but you can see that's a very dynamic number that changes over time. So these are also ways that we could assess positive predictive value and indeed relative risk by comparing the high versus the low scores, for example. And that HeRO has stayed very well calibrated for decades. These are 3 different time epochs of HeRO scores, and the calibration curve that we saw on the other page has remained well calibrated across time. I will say that this is unpublished. Finally, if we change the definitions of sick and well, we'll get very different measures of sensitivity, specificity, positive and negative predictive values, area under the receiver operator characteristics curve, and risk ratios. And each of these are, I think, defensible ways of defining sick and well that come up with very different results. And it makes it very difficult to compare 2 different models that might be from developed by different groups, because very rarely are 2 people actually measuring metrics of model performance on the same data set with the same definitions. So on one data set, if we look at each hourly HeRO score, define sick as within 48 hours of a positive culture, and well as more than 10 days after a positive culture, we get sensitivity of around 45 and specificity around 86. And I'll just skip forward because the purpose is not to memorize these numbers, but to see that if we're looking at the maximum daily HeRO score to predict a culture, positive culture in the next day, up to 48 hours, that would be, and we're going to be plus or minus more than 10 days from any culture, we get sensitivity of 61% and specificity of 89%. Risk ratio changes from 5x to 11x. Final thing to say is that 53% of spikes in one analysis were associated with suspected or proven infection. So this is yet another way that we could assess positive predictive value. So the summary of this slide is that the metrics of HeRO performance are strong, but they vary based on definitions. Again, we'll see sensitivity can range from 44% to 92%. Positive predictive value can range from 4.5% to 53%, just depending on how you set up the problem. HeRO, though, responds to inflammatory events. Rising HeRO score indicates significant risk of infection, but the clinical implications of these metrics to clinical care were unknown. Could this have caused additional testing or additional antibiotic usage? What we really needed to do was a randomized controlled trial. Last thing I'll say, or actually a couple more things to say, HeRO also rises prior to necrotizing enterocolitis. So here's 3 different publications showing that. HeRO rises for UTI and meningitis as well. HeRO is predictive of both need for emergent intubation. In one analysis, it was the best univariate predictor with an ROC of 0.81, as well as readiness for extubation. And we actually worked with one of our customers in Wales to develop extubation readiness models, and these are available on our website. If you go to heroscore.com/extubation, you will see these 2 models of extubation readiness and extubation success that you can enter basic demographic and clinical variables into and get a risk. You can also, if you have them, enter HeRO scores and get indeed a better risk assessment or readiness assessment for extubation. HeRO is also related to severity of brain injury, a couple of publications demonstrating that as well. Um, Interestingly, HeRO is highly predictive of mortality as well. If we look at the 7-day mean or median HeRO score plus demographics, we have a 92x difference in rate of mortality for patients that are in the top half of that model versus the bottom half. So it really is a very strong and important predictor of mortality as well. Okay, so that brings us to from HeRO development and predictive accuracy and ability into the HeRO randomized control trial. So it was all predicated on the idea of improving antibiotic timing. It was well known among adults at the time that delays in antibiotic therapy were measurable in terms of mortality. An hour's delay was measurable in terms of mortality. Indeed, in the years since we started the randomized control trial, publications specific to neonates are now available, and it's been shown that mortality, length of stay, NAC, and BPD were all lower among septic neonates that received an early antibiotics, less than 3 hours versus greater than 3 hours. And I think a CHOP paper shows that each 30-minute increment in time to antibiotic administration was associated with significantly increased mortality at 14 days, an odds ratio of 1.47 per hour, both at 14 days and 30 days. And so the thinking going into the randomized control trial was, if a delay in treatment causes outcomes to deteriorate, what's the flip side of that coin? Could an earlier improved diagnostic timing cause outcomes to improve? And so we embarked on the largest ever randomized control trial among preterm infants, where there were 9 hospitals. We randomized 3,003 patients to either receive standard of care or standard of care plus HeRO monitoring. It was a pragmatic studying design, meaning we did not mandate that clinicians had to do a CBC at a score of 1.7 or get a blood culture at a score of 2.9 or start antibiotics at a score of 4.2. We simply turned it on, trained the clinicians on what the score meant and how it was developed, basically the same things that you saw earlier in the presentation, and then let them take care of patients as they saw fit, again, with half the patients where the HeRO score was available and half the patients where the HeRO score was not. And then we tracked outcomes differences. Baseline demographics at enrollment, there were no statistically significant differences, meaning we did a good job enrollment. Among outcomes, there were statistically significant differences in all-cause mortality, mortality after infection, and 2 different measures of discharge time, both looking at patients discharged alive and prior to day 120, or median PMA at discharge for survivors with a positive culture. Here are the survival curves. This is all patients in the randomized control trial, where day 0 is the day of randomization. I think it's quite clear which group we want our patients to be in. And here is only the patients that had a positive blood culture. Time 0 is the time of the blood culture. And again, I think it's quite clear that we would want to see our patients in the HeRO monitored group. That, to summarize, it was the largest randomized control trial ever conducted among preterm infants. There's a 20% reduction in all-cause mortality, with a number needed to treat to save a life of 48 very low birth weight babies. It was a 40% reduction in mortality after infection, number needed to treat 12 infected VLBW patients to save 1 life, and there was reduced length of stay after adjusting for survival. Now, this, I get asked questions quite a bit, and so I want to take you through a pretty dense slide here, because I think it is important to really jump in and dive in into this one. So now we're going to look at the outcomes of the randomized control trial, but we're going to do so separately. On the left in yellow for patients that were septic, and on the right in green for patients that were never septic. Now in blue, we're going to look at baseline demographics, And we can see that among both the non-septic patients, there were no statistically significant differences, and among the septic patients, there were no statistically significant differences. Again, we did a nice job randomizing there, and so the patients enrolled into the study were essentially the same, whether they were randomized to HeRO display or non-display. When we look at the non-septic patients and compare those in the HeRO display to the non-display, and now we look at outcomes, there were, again, no statistically significant differences in length of hospital stay, days on antibiotics, days alive and not on mechanical ventilation, and in-hospital mortality. However, when we go back over here to the left, look among septic patients, these are the patients that did need treatment, how was that altered by whether or not they were randomized to HeRO display or non-display? And indeed, there was a trend, but not a statistically significant trend, toward a change in hospital length of stay, and indeed more antibiotic treatment days, more days alive and not on mechanical ventilation, and more days and improved mortality, I should say, in two different metrics, hospital mortality and within 30 days of sepsis. So to summarize that, HeRO allowed clinicians to target the sick patients with antibiotics at the right time and improve their outcomes in both length of stay, discharged alive and without mechanical ventilation, days alive and without mechanical ventilation, and in-hospital mortality. So HeRO allowed the clinicians to target the right patients with antibiotics and improve their outcomes without changing outcomes for patients that were never sick. So without adding an antibiotic burden to the patients that were healthy. And indeed, this analysis does not adjust for the improved mortality. If we adjust for the improved mortality by looking at days alive and without antibiotics, days alive and without a blood culture, or days alive and without an unnecessary blood culture, we can see that all of them trend in favor of HeRO, and indeed the days alive and without an unnecessary blood culture was statistically significant. So to summarize, overall antibiotic usage was not statistically significantly different between the two arms of the randomized control trial when looking at all patients. However, when we look at septic patients separately, those patients did indeed receive more antibiotics, but it improved their outcomes. Healthy patients had no change in antibiotic usage, and there was no additional testing and treatment burden on the HeRO display patients after controlling for the fact that survival was improved. Because if a patient unfortunately does not survive, of course, they do not get antibiotics, they do not get additional testing. And so these are competing outcomes that need to be controlled for the improvement in mortality. Okay, neurodevelopmental outcomes. So many of the ELBW patients that were enrolled in the randomized control trial were followed up at 18 to 22 months. And so the findings there were first that death at 18 to 22 months was improved, that mortality improvement in the NICU and after sepsis was durable. And then we analyzed patients separately, like we just saw on the previous page, for the effect of HeRO monitoring on outcomes at the 18 to 22 months. And when we looked at the septic patients, we can see that all composite outcomes that included death and any of the components of neurodevelopmental impairment, so that's death or blindness, death or low language, death or severe cerebral palsy, all had statistically significant improvements for those patients that were septic, with no change, again, no change in outcomes for patients that were not sepsis. So again, HeRO allowed improved outcomes among sick patients without changing the outcomes in any negative way for patients that were never septic. Then we took those data and we developed multivariable models to predict death or neurodevelopmental impairment. We started by noticing that if we are looking along the x-axis here as good outcomes with no or mild NDI, moderate, intermediate NDI, or profound NDI in red, or death in slate gray, we can see that HeRO scores were elevated among those patients that had the poorer outcomes. And indeed, if we look at it this way, we can see that on a daily basis. So in green, we've got no or mild NDI. In red, we're plotting moderate, severe, profound NDI, or death. And we can see that those patients that went on to have a poor outcome have higher HeRO scores every day that they are in the NICU. And if we register that to time of culture, we can see something I think quite profound here. So time 0 is the time of culture. We can see that 15 days prior to sepsis, patients had essentially identical HeRO scores, whether they went on to have a bad outcome, a bad neurodevelopmental outcome, or a good neurodevelopmental outcome. And indeed, they start to separate about 7 days prior to sepsis, as we would expect higher HeRO scores for those patients that had the poorer outcomes, and then they never go back. And so these patients, indeed, we're seeing that sepsis is an important trigger of the inflammatory process that ultimately results in neurodevelopmental impairment. And then finally, we use these data to develop these parsimonious models, snapshot models each day in the NICU, using demographics, sex and birth weight, clinical data, ventilatory status, and then HeRO improved those demographics and clinical models. So you can see in blue is the trend of the ROC of each daily snapshot over time in the NICU, and in red, the model that also includes those same variables plus HeRO. And in all cases, HeRO is improving the ability to predict long-term outcomes in these patients. And one more slide that came of the same work, but I haven't published yet, and hope to work this into a future publication, but I think it's absolutely fascinating. So here we're looking at average HeRO score on the y-axis by PMA. And what we can see, as you would expect, patients with the lowest PMA, these patients with the lowest gestational age, have the highest HeRO score, and it stays high and then starts to kind of follow a similar trend. But indeed, these patients with the lowest gestational age never get down to the baseline of patients that are born at a higher gestational age. These patients at the lowest gestational age carry this inflammatory burden with them throughout the stay in the NICU and beyond. And I think this has a lot to say about the differences in outcomes that we see across gestational age. Okay, we also did a cost effectiveness analysis for HeRO, results from a third-party perspective, a payer perspective. In the United States, the cost to save a life with HeRO monitoring was $35,000. So really, truly peanuts when we think about what we spend to save the lives of a neonate. Indeed, that's less than the average cost of saving a life in the NICU. In other words, implementing HeRO in a particular NICU will actually reduce or improve the cost effectiveness of that NICU. In bootstrapping that estimate, 95% confidence of that estimate was below $440,000. And from a hospital perspective, a unit that implements HeRO monitoring will increase both top-line revenue and bottom-line profit. So it really does make sense from a societal perspective, as well as from a hospital perspective, to adopt HeRO monitoring. It is cost effective, and it actually improves the bottom line of the hospital. So what was the RCT mechanism? How did this happen? How was it that patients where we turned on the HeRO scores for display to the clinicians actually improved outcomes or experienced improved outcomes? Let's go back to this 5-day trend that we saw earlier. And again, remember, this was a control patient in the randomized control trial. This was a patient where we were generating HeRO scores, but not displaying them to clinicians. And indeed, these were alarm bells that were ringing then in this patient that no one could hear and respond to. But these spikes in HeRO score are less prevalent among the patients randomized to have HeRO displayed. What that means is that the patients where the HeRO score was displayed and the alarm bell was ringing, but the clinicians could hear the alarm, were having the HeRO score diagnosed at the second or the first spike in HeRO score, not the third. And so we see that when we plot all the patients, 350 odd patients that were in HeRO control in red here and HeRO display here in blue, we can see that there was a statistically significant difference in the mean HeRO score among those 300 patients. Now, it looks like kind of a smooth trend. What we're seeing over here on the left is very much spikes in the HeRO score over time. But again, this is 300 patients smoothed out. And you have to imagine that, yes, in this patient, there was a spike that occurred, 36 hours and 72 hours prior to the diagnosis. But in another patient, it might have been only 36 hours. And in another patient, it might have been only at 24 hours. But the bottom line is that there was this statistically significant difference in the mean HeRO score among these patients that were randomized into control, where the alarm bells were ringing, but nobody was responding to these alarm bells. And so by altering the timing of the diagnosis, accelerating it by sometimes only 2 hours, sometimes 48 hours, on average about 16 hours, you're potentially nipping that infection in the bud with treatment before the infection has gone systemic, before organs start shutting down, before you have the really bad outcomes. Okay, let's talk about clinical workflows. So we do not tell HeRO customers how they must implement HeRO. It was, again, a pragmatic randomized controlled trial. But what we will do is we will share with you other customers and their clinical workflow and help you develop a clinical workflow that works best for you. I want to pull your attention to a clinical workflow that was published by our customer in the Netherlands, where they followed this flowchart. I won't talk you through everything. I'll just kind of summarize it here on the left. Basically, what it says is if a patient is sick, treat them like they're sick, regardless of the HeRO score. If an otherwise healthy patient has a rising HeRO score, do a physical exam. If they show signs of illness, then treat. And if there are any other reasons to explain that rising HeRO score, respiratory distress, again, brain bleeds, surgery, anesthesia, eye exam, then you're done. You don't need to carry on. That explains that rising HeRO score. But if not, then get labs. They get CBC, procalcitonin, they get IL-6, procalcitonin, and CRP. If those labs are abnormal, then treat. So it's just that simple. HeRO in and of itself is not a diagnosis, but a rising HeRO score in absence of an explanation is a call to action to get that physical exam, get those labs, and if those are abnormal, then that would lead to treatment. When they published their data on the IL-6, PCT, and CRP that were prompted by those HeRO scores, I think we can see here that there's a clear difference. All of these labs, including the much maligned CRP, in the presence when prompted by that rising HeRO score, are indeed good discriminators of infection. And that's something that we've seen as well, is that labs have decent discriminatory value, and HeRO has decent discriminatory value for sepsis. But put those two together, a patient with a high HeRO score and three abnormal components of their CBC, has a 45% probability of death, UTI, or sepsis in the next 7 days. So it really is, HeRO is new information that you can combine with existing tools to make a better or more timely assessment of infection and, again, improve outcomes. And indeed, what they published was that the NSOFA score, so this is a measure of morbidity at the time of infection or at the time of diagnosis, was statistically significantly reduced. Mortality trended downward from 10.3 to 7.6%, not quite statistically significant. Days of antibiotic use per 1,000 hospital days also trended down, p equals 0.06, and they concluded that HeRO altered the NSOFA score and reduced that NSOFA score by altering the timing of the diagnosis, catching the trend in that NSOFA score earlier before it had risen as far. Here's another protocol that we published as well. It follows, again, the same general idea. And indeed, here is another of our customers and their clinical protocol that they use. And again, what we feel our job here is provide you as a potential customer with resources and allow you to tune a protocol to meet your needs. So again, to summarize the clinical evidence, HeRO identifies abnormal heart rate patterns that are associated with cytokines, those mediators of the inflammatory response. Think of it as a non-invasive, real-time window into the inflammatory process that can be both predictive of sepsis and a measure of the burden of inflammation, and can be associated with sepsis, UTI, necrotizing enterocolitis, meningitis, respiratory decompensation, brain pathology, and mortality. It's been shown to improve outcomes. That's all-cause mortality in the NICU, mortality after infection, mortality in these neurodevelopmental follow-ups at 18 months, mortality or neurodevelopmental impairment after sepsis, length of stay among survivors, and hospital revenue and profit. And it does so, it improves these outcomes without increased in testing after controlling for the mortality improvement, and better antibiotic targeting, hitting the right patients with the right antibiotics at the right time when you can improve their outcomes without adding to the burden of antibiotics on healthy patients. Okay, so what else are we doing? I'll just go through 5 projects that we've got going on right now. So over here on the left are graphs from 2 different publications where we showed that that HeRO predicts mortality among patients that were randomized in the support randomized control trial to both low and high SpO2 targets. So this is what we'd expect. Again, that mortality prediction, the very strong prediction of mortality that I showed you several slides ago, holds up both at low and high SpO2 target ranges. And in a separate publication, we showed that among patients with low HeRO in the first 5 days, after birth, outcomes were better if those patients were randomized to a low target SpO2, right? And that's turning the results of support and neoprom on their head, where outcomes were better for patients that were randomized to high target SpO2, that were lower mortality at high SpO2, but that high SpO2 also had a higher rate of ROP and BPD. But among patients with low HeRO scores, and that is a low risk of infection, low risk of infection and low deaths, those patients too and increase their burden of morbidities, BPD and ROP, when again, you can have a very good idea that those patients are at low risk of mortality. So we hope to start an interventional study on that early in 2027. We submitted to the NIH a very strong STTR proposal that got caught up in the last government shutdown, where the STR program basically ended for 6 months, and it's taking about 6 months to restart that program. I had hoped that in late 2026 we would start this interventional study, but that's been seems to have been held up for a year, and certainly we hope to get started on that as soon as possible. We're also working on a clinical decision support tool that will layer on top of HeRO that we are calling HeRO Plus. And we are finalizing that model and going to externally validate it on a new data set. And that work is underway right now. But the headline news there is that by adding some additional demographic variables and clinical variables on top of HeRO, we will be able to contextualize, say, across PMAs, the HeRO score. What would be considered a normal HeRO score might be different for a 27-weeker than a 34-weeker. And so we're contextualizing the HeRO score across PMA, adding in ventilatory status, et cetera, and improving the model performance by about 50%. So one way to look at that would be to say at the same sensitivity, we can increase positive predictive value by about 50% and thus lower false alarms by that ratio, and hope to have that out and available to existing customers and new customers just as soon as we can. We're also working with a group, UVA, University of Alabama, Birmingham, and WashU, on a version of HeRO that is tuned for neonatal opioid withdrawal syndrome. We're calling that HeRO Fresco. We've reported results in a couple of different publications and in a couple of recent PAS meetings. The bottom line is we have a new model, again, tuned for severity of neonatal opioid withdrawal syndrome. We can see it's got very good calibration in terms of predicting treated nows versus observed treated nows risk. We can see that over time, that score goes up for patients that ultimately go on to have treated nows. And when we look at this score for control patients, so these are healthy controls versus patients experiencing nows that have a good ESC score versus one or more components of their ESC score that are abnormal, we can see that HeRO scores rise. These HeRO Fresco scores rise with increasing severity of neonatal opioid withdrawal syndrome. So we're excited about that technology. And again, have a very good STTR proposal with very good scores that has been held up by this 1 year, effective 1 year shutdown in the STTR program. But look forward to continuing that work as the program comes back to life, so to speak. We're also working with Children's Hospital of Los Angeles to use accelerometer data as an additional physiological signal. Of course, I think we all know that lethargy is a very strong predictor of sepsis. Also, motion can be used as a predictor of neurodevelopmental impairment as well. And so we see this nexus between infection, autonomic dysfunction, motor control, cytokines, heart rate variability, and ultimately neurodevelopmental impairment that we hope to add to. We hope to use this accelerometer data to improve our models of sepsis and also improve our ability to assess and predict neurodevelopmental impairment in these patients. And so far, we have enrolled exactly 3 patients. So this is just getting off the ground, but something that I'm very excited to be working with the team at CHLA on. Finally, we're working with Lurie Children's on nutrition and growth models. This is another NIH-funded STTR grant We have collected very high resolution data, including all enteral and parenteral nutrition fluids, feeds, and orders, tied that back to orders, and then used natural language processing algorithm to decompose those orders into its components and be able to very accurately assess the energy content delivered to these patients, not just ordered, but delivered to. We hope to extend that to macro and micronutrients, so have a really complete picture of the delivered enteral and parenteral nutrition that these patients have received, and then be able to model growth from that. Right now, we have 100% accuracy in calculating caloric density received in a small test data set, and very positive growth failure models, 92% accuracy in modeling growth failure. Of course, we hope to improve those models with this richer set of both energy and macro and micronutrients, and then develop predictive models that can say which patients are likely to experience growth faltering in the future, and potentially be able to predict how much particular patients will grow. Okay, so just want to run through a couple quick thoughts on predictive models and then open it up for questions. So, we've known for a long time that it's actually a better predictor of sepsis to know that the CBC was ordered and drawn than it is or was to know the results of the CBC. And at first, that makes no sense. How can that possibly be? Well, the presence of a CBC is a surrogate for clinical suspicion, right? You don't get a CBC unless you think something's going on with this patient. And so the presence of this CBC is a surrogate for clinical intuition. And it turns out that that clinical intuition is a better predictor of sepsis than the results of the CBC. The EPIC sepsis model is built on those surrogates of clinical suspicion. And I'll just read the quote: "The EPIC sepsis model does not help to identify cases before clinical recognition has occurred. Despite the EPIC sepsis model's high area under the ROC curve, positive predictive value, and sensitivity, none of these predictions are clinically meaningful." And that's why it's so important to judge these models not on accuracy, but on actionability. Do your due diligence, but know what you're looking at. Are the predictor variables surrogates for clinical suspension? In fact, are they components of the composite outcome that's being predicted? I read and reviewed papers where that's exactly what they're doing, using a component to predict the composite. It's incredibly frustrating to see that make its way into peer review journal articles. And are those predictor variables, independent variables, orthogonal to what the clinician already knows? Regurgitating back to the clinician something that they already know is not going to improve outcomes. Adding new information to what the clinician already knows is how you alter and improve outcomes. Next bullet: is the model being evaluated on easily identified cases and controls, or on a representative sample that approximates the clinical challenge of making a decision on every single patient in the unit, that messy middle? It's not hard to find a group of patients that are clearly healthy and clearly sick, and for the model to be able to discern the difference, but discriminate the difference between those two. The difference is again, that messy middle, the patients that you're on the fence about, that you might not even be able to agree on whether this is sepsis or not. I've been doing this for close to 30 years, and I still don't know what sepsis is, because we have these competing definitions. Is clinical sepsis or not? Do we need 2 positive cultures, et cetera, et cetera? If you can't agree on that, if it's difficult to agree on that, how can you get a model to do that? It becomes very difficult. But those are the real cases that you have to have an answer for. And so a lot of papers that I read, they just sweep that under the rug and only analyze clear cases and clear controls and make the model look better, but it doesn't approximate real clinical practice where you have to make a decision on every patient. Next bullet, are there clear thresholds that would prompt a clinician to get lab work, draw blood culture, whatever the action is? Is it being evaluated on those thresholds, and do those actions have the potential to improve the patient outcome? Again, with HeRO, an action threshold prompting a diagnosis that leads to early antibiotic therapy. That early antibiotic therapy is clinically, intuitively going to lead to improved outcomes. It all made sense and indeed played out in the randomized control trial. And is the predictive model being evaluated in time sufficiently temporally in advance of the diagnosis or the outcome to prompt an intervention that has time to improve the outcome? Again, with sepsis in neonates, we're seeing that even a 30-minute window is measurable in terms of mortality and relative to antibiotic therapy, the initiation of antibiotic therapy. So certainly a HeRO score where we're measuring it in the 24-hour or 48-hour or 72-hour window in advance of the diagnosis does have that opportunity in time to improve the outcome. And finally, do you really care as a clinician about sensitivity, specificity, and area under the curve? Those are backwards looking metrics, right? Sensitivity is the probability that the test will be high for a patient that you know was sick. And specificity is the opposite. What is the probability that the score will be low for a patient that you know was healthy? So we take the status of the patient and we look back in time and say, what was the score? Well, that's not clinical practice. Clinical practice is about taking what we know now and what can we infer is going to happen for this patient based on what we know now. That's positive predictive value, negative predictive value, relative risk, odds ratios. These are the metrics you care about because these are the ones that put patients, that risk stratify patients and allow you to take appropriate action based on the risk category of that particular patient. Okay, with that, I will take questions and discussion. I'm seeing, yeah, so we'll open it up for questions now.
I can also raise their hand.
Yeah, feel free to put questions in the Q&A or raise your hand. I think I will see that if you raise your hand as well. And we can open up your mic. Okay, well, it's 2 o'clock, and I think that's our window. So I want to thank everyone for attending. Please feel free, if you do have questions, to reach out. I think if you reply to the original email, one of us here will get it, and we will look forward to engaging in a further discussion with you. So thank you very much for your time, and appreciate you attending.